We're going to get started in a few minutes. I'm going to give it one more minute and then we'll get started. All right, Carrie, do you want to get started?
Yes, let's get started. Welcome everyone and good afternoon. Thank you for joining us today. My name is Carrie Shannard-Kunders. I'm the Executive Director of the South Dakota Board of Pharmacy and I chair the NASCSA's Education Committee. I'll be hosting this afternoon's webinar along with Kathy Keogh from NASCSA. Hopefully you read the scrolling information while waiting for the webinar to start with, which includes information regarding our sponsors, a NASCSA disclaimer, housekeeping items, and announcements. Today's webinar and all of our webinars throughout the year would not be possible without the generous support of our sponsors. So thank you to our sponsors. Also, the NASCSA Travel Scholarship deadline has been moved to the June 16th. You have 2 more days to apply, and the award amount has been increased to $2,000. This is a fantastic way to attend one of the best conferences in the United States. It's really great. So apply for that scholarship if you need it. And thank you for taking time out of your busy schedules to join us for today's webinar. Xylazine as an emerging threat, update on trends and responses. We're very pleased to have Dr. Traci Green with us today to speak on this very timely topic. South Dakota just had its first Xylazine case last week, but most states have been seeing it much more frequently. So we are really fortunate to have the Xylazine expert doing this webinar for NASCSA. By way of introduction, Dr. Green is an epidemiologist whose research focuses on drug use, opioid use disorder, and drug-related injury. She earned her Master of Science in Epidemiology and Biostatistics from Yale University and a PhD in Epidemiology from Yale University. She helped design the ASI-MV, a real-time illicit prescription drug abuse surveillance system developed by Inflection. Prior to joining the Heller School at Brandeis, she served as Deputy Director of the Boston Medical Center Injury Prevention Center, Associate Professor of Emergency Medicine and Community Health Sciences at Boston University Schools of Medicine and Public Health. She is an adjunct professor at the Warren Alpert School of Medicine at Brown University, where she co-directs the Center of Biomedical Research Excellence on opioids and overdose at Rhode Island Hospital. Dr. Green helped co-found www.prescribetoprevent.org for pharmacists and prescribers, and its companion site www.prevent-protect.org for families, patients, and community organizations. She serves as advisor to the Rhode Island Governor on Addiction and Overdose and consults for the Center for disease control and prevention in the high-intensity drug trafficking areas on public health and public safety opportunities. She served on the board of scientific counselors for the CDC's National Center for Injury Prevention and Control and 2 recent National Academy of Sciences, Engineering, and Medicine's committees pertaining to opioid pain management, regulatory strategies to address opioids, and medications for opioid use disorder. Her research is supported by the CDC, the National Institute on Drug Abuse, the Agency for Healthcare Research and Quality, the Patient-Centered Outcomes Research Institute, the Bloomberg American Health Institute, and the Department of Justice. And RISE, M-A-R-I-Z-E-M-A, and I'm not sure what that is. So Traci or Dr. Green, we will let you go forward and talk to us about Xylazine.
Thank you so much. Thank you, Carrie and Kathy, and thank you for the invitation to talk with you all today. I had the pleasure of being one time in the presence of one of the annual meetings and to talk about some of the research I was doing at that time with a prescription drug monitoring program. So I'm excited to be here in a virtual space to talk about some of the challenges with Xylazine. So today I'm going to, let me just share my screen and share some of my slides. So this emerging threat declared just recently by the Office of National Drug Control Policy gives us pause and an opportunity to really think about what these trends and what might responses look like. So that's what I'm going to try and cover today. I had thankfully a lengthy introduction, so you have a sense of where I am. I sit at Brandeis at the Heller School for Social Policy and Management in Massachusetts. I don't have any disclosures today to share. So just in terms of to center us, Xylazine is an animal tranquilizer. It's not approved for human consumption. You may be familiar with it, though, because it is a substance that is often used in the care of veterinary medicine. In its general sense, we understand its function as decreasing the release of excitatory neurotransmitters, such as norepinephrine and dopamine, and that affects the central nervous system. Peripherally, it also acts as a vasoconstrictor. Why is this bad in humans, in particular? Because it leads to the sedation, as one would expect with a tranquilizer, but also muscle relaxation, respiratory depression, hypotension, bradycardia, and decreased response to painful stimuli, and in some cases, death. Xylazine, as we know, is authorized, so FDA is familiar with it, and you may be too, but only for veterinary use, and it's not a controlled substance. It's not scheduled as a controlled substance at the federal level, though some states are changing that. Nationally, the drug supply suggests that while we don't have human consumption, it is increasingly found in the drug supply that people and humans are using across the United States. A study from Philadelphia, and much of the data coming from the Xylazine exposures and harm effects come from the Philadelphia area. But in particular, the national data suggests that those increases in Xylazine presence, especially in heroin and fentanyl, changed from a very small proportion of 22% to over 30% in 2019. And in the first quarter of 2022, drug checking that was done in the city of Philadelphia showed that Xylazine was detected in basically nearly every heroin sample that was collected. And that continues to be the case. Upwards of 90% of the illicit opioid supply in the Philly area is contaminated or contains Xylazine. It does have a street name of Trank or Trank dope in that area, and that continues to be something we see throughout in the Northeast. It has been a medication, though, that is known to other places in this country, Puerto Rico in particular, as a place that has seen Xylazine use for a long time, both orally and by injection. From back to the 2000s, literature and research from colleagues there have really showed that in times when heroin was not as accessible and methadone was extremely constrained, that Xylazine was used in diverted ways, and also to help with withdrawal symptoms. There's some excellent documentation, and the YouTube link that is there may be of interest for some as you learn a little bit more about Xylazine. Xylazine-involved overdose, though, is an important trend. Overdose deaths where Xylazine is detected is increasing, but the mechanism by which Xylazine is causing or contributing is not clear. It may be more that it is present rather than that it is causal. And that's part of the many questions that we have about xylazine at this time in humans. So a study that looked at US 10 different jurisdictions across US census regions reflected that xylazine's presence rose dramatically in overdose deaths from 2015 to 2020. And again, that highest prevalence was in the Philadelphia and the Northeast area, with the sharpest rise in that region as well. But to be clear, we are seeing xylazine present in the drug supply in nearly every state in the country. And the overdose death data, though, does not indicate that it is at the same level as, say, fentanyl, for instance. On the other side of non-fatal overdose or emergency department data, this is where it's extraordinarily lacking. Both in the medical examiner data and the emergency department data, a challenge is that we are not testing for xylazine. Most emergency departments, if they do test for xylazine, it's done at the request of the patient, or the clinician has to indicate it, and then they send it out. So most hospitals are not providing xylazine testing in a clinically responsive time frame. So what we learn is mostly from retrospective studies, such as the one that from an ED-based study in Philadelphia that found that fentanyl positive screens in patients who had a urine drug screen for a fentanyl exposure also found high rates of xylazine exposure, and that is running at 78%. So a high degree of overlap between fentanyl and xylazine in Philadelphia, as we've been continuing to, and that's sort of where those ED data are showing us. While we have a new data point from 2023 of this year from a multi-site ED study out of assisted by the NMS lab community partners, have found that xylazine involved overdoses were less severe than overdoses involving just fentanyl. So to be clear, though xylazine was on board, there were less severe overdoses that were seen compared to those that had just fentanyl without xylazine on board. Things like cardiac arrest and respiratory depression were not as problematic as those overdoses that were involving just fentanyl. This is an important aspect to consider. Locally, in my neck of the woods in Massachusetts, we've been collecting data through what we call community drug checking, and I'm going to introduce you a little bit to that. But the data that we've gleaned from that community drug checking work, which was coordinated through my team in Massachusetts and our community partners engaged in this same activity, we found xylazine a progressively higher proportion since 2020, to the point that we see in about a third of our opioid samples, heroin, dope, fentanyl samples from in 2022 and 2023 contain xylazine as well. So we saw those initial signs early in 2021 during the pandemic, and that continued to increase in the geography as well as the proportion of xylazine that made up the sample. So was it present, but then how much was present? The form in which it was taking was primarily in powders, but we also saw in pressed pills like the one that you see there, the fake Percocet, if you will, that people talk about, also contains xylazine. And just 2 weeks ago, I saw my first instance of a crack sample that had apparently we have problems with stimulants being contaminated with fentanyl. And in this case, it was a crack sample that had fentanyl, and the fentanyl contained xylazine. So in places where there is known contamination, we should anticipate to see xylazine also in those stimulants. So if that is a rising trend or an issue in your community and in your state, it's probably another place to just keep an eye out for. But the vast majority of the exposures appear to be in opioid samples. But just to take a step back, community drug checking in Massachusetts takes the form of what we devise as MADS, or the Massachusetts Drug Supply Data Stream, which is an effort that's a collaboration between the state, SAMHSA funds, and CDC. And in this case, we work with our community harm reduction partner sites and in collaboration with the police department, or in sometimes a district attorney, and individuals who may be coming to the site to provide, to get naloxone or to provide used syringes and get new sterile syringes. Those harm reduction partner sites also collect a remnant drug. So it may be a used cooker or a cotton, or it may be a baggie or a wax fold that has small remnant drug left in it. And they provide that as a donation to be tested. They may do that prior to use or post use. Either of those pieces of information are helpful for both the consumer, for the program to advance their programming, and then also at a public health level, because we can identify at a geographic site and a state the trends such as you saw there. Had it not been for community drug checking, I actually don't know when we would see xylazine in Massachusetts, because we are not thoroughly testing at our emergency departments. The medical examiner, it's not hitting our overdose deaths in the same way, and we are suffering quite a many amputations. So I'm not sure how many people would have to have been quite marred by and maimed by this particular substance before we'd know it was there. So I personally feel like this is a really important strategy for a lot of states to start to think about embracing. And they have actually. This project has been taking good form in a number of states. So regionally, they're now the purple points there are all our Massachusetts sites. The gray ones are emerging ones. So new sites that are coming on board. And we have some funding from the Office of National Drug Control Policy and the CDC Foundation on the red line that all goes up and down the I-91 corridor to build out drug checking there. And in Rhode Island, a couple different funded projects. And they all feed and are incorporating data into Street Check, which is a free website you can access. And we are incorporated that as a tool to make it easier to streamline the process of drug checking, both collection and entry, managing the analysis, and collaboration with the labs when they provide additional testing results. That makes it easier for everyone to see the data. And it looks an awful lot like what we maybe have devised for prescription drug monitoring programs, because a lot has been learned from society along the way of how to present and incorporate data and access to data. So that is a way to visualize drug trends in the illicit market. In Massachusetts, the things that are tested in community drug checking programs are, like I said, those once used cookers or cottons, everything to, we do also test pipes, and the amount is in the range of 1 to 5 milligrams. So that's about it's actually a quarter of a grain of rice, so very small, true remnant drugs in this instance. That's because, we have good data, well, relatively good data, I think, from DEA at the level of importation and customs and border. We have information from our highway and drug highway initiatives and our state police at the larger distribution level. But what we lack is information about what people are actually consuming. And we only find that out when people die or are suffer morbidity and have that instance be tested. So this community drug checking kind of focuses on that street level distribution and use to allow for information to both go follow within that group for feedback, as well as for community partners and states to strategize and understand what they're dealing with. So just to close up drug checking, we have a lot of tools that are used. Perhaps you've been familiar with devices like fentanyl and benzodiazepine and now xylazine test strips. These are all immunoassays that are incorporated into and provided in many of the states that have decriminalized this or legalized drug paraphernalia entirely, like Minnesota. But these tools for being able to detect the absence or presence, if you will, of a number of substances. And to this more comprehensive drug checking are added things like the alpha FTIR, the spectrometer that you see on the left-hand side, which allow for kind of real-time detection of the contents. A lot of times that's active and inactive cuts. And when there's a substance, for instance, like xylazine, you can definitely see it on the FTIR as well. But everything goes out to offsite labs for additional testing, and then are interpreted, if you will, by our medical toxicologists, Dr. Whiteman and Dr. Kotalski. And in that way, we have a better, fuller understanding, which is really how we started to see xylazine and wonder at these levels what it might be doing to people and what we might need to be preparing better for. And like I said, all of this gets simmered into the streetcheck.org website to allow for trends. And so that's sort of where we began to unpack, if you will, the xylazine problem, which really reflects, as you've been sort of seeing, the research indicates that we don't have a safe dose or an understanding of what a safe dose of xylazine is. And so the laboratory research that is provided to and was submitted to FDA for approval for animals really shows inconsistent effects of dose for different sized animals. In fact, a number of veterinarians in preparation for this and other talks reflect that they don't tend to always like to use xylazine because it can be inconsistent and they have to prepare for what may happen if the sedation is too long. So we also have data suggesting that there may be genetic influences on how dose affects individuals. There may be things associated with biological sex in humans that may also affect. So we do, however, the data seem to suggest that there may be a dose response. So at higher doses are more problems with health, and at lower doses there may be less problems with health. But it's unclear what those symptoms and triggers that create harm may be. And this is the source of quite a lot of epidemiologic and research investigations that we're myself and others are trying to forge ahead with and to hopefully share back to the community as we learn. So other big questions besides dose, how much of the dose is of concern, but also is the route of administration. So by that, I mean, is smoking as harmful as snorting, as harmful as injection? We do see that xylazine related health effects are problematic, and in particular, talk a little bit about the abscesses as they emerge, but some of the skin related challenges, the painful ulcerations are potentially associated with route of administration that's not by injection and not at the site of injection, but at extremities or at different parts of the body. So a lot more is is still to be known about xylazine and what mediates risk. At this point, really the focus is to minimize xylazine exposure and to minimize the dose. So as the safest approach. This may be really hard for people to do, however, because it's hard to detect and it's not obvious from the eye and by visualization or a smell or other derivation. And it's also not detected in clinical settings as easily. So the other larger big question that I end up getting a lot is why actually is xylazine in the drug supply? What do we think is why it's here? There's a lot that has been hypothesized. So I simmer down some of the things that we've been hearing and some of my own thoughts on this, but some of they kind of bucket into ideas of cultural adaptation, that there are people that prior use of xylazine and it's a known substance in some communities and in some parts of the country. And that makes it, because it's accessible and it's not controlled, that through these process of adaptation of xylazine is a natural choice for a sedating drug. Other people feel that this is, there is a demand and a purpose that xylazine's presence is serving. And this may, there's some who are articulating that the social isolation and some of the social ills that our country is experiencing, especially that were exacerbated during the pandemic, that sedation is a sought out feeling to cope with these challenges. Another approach is thinking that this is an economic choice because people have, the xylazine requires fewer use episodes. So because xylazine is action, while it's short, it lasts a long time. The sedation can mean that people are not using as many bags or as many have to purchase as much. So economically, it's a better choice for people who are using on a daily basis. For some others, experience of fentanyl has created a fentanyl withdrawal that is challenging, and because of the short acting and the short nature of the short legs, if you will, that people speak of with fentanyl, that people are having to use many times a day or suffer the kind of withdrawal that they're experiencing from fentanyl is problematic. And so treating a opioid withdrawal can be through sedating medications, and xylazine has a purpose in that form. And then still others we're hearing from, especially for folks who are unhoused, because they have challenges with sleeping and may have be needing to use stimulants to stay safe or to stay awake from violence, that at some point they need to sleep, and the xylazine has a purpose in that regard. So might housing, but this is a challenge that people talk about as a potential purpose that xylazine may be serving. Final thoughts on that, market adaptations. We lack heroin in many of our communities as fentanyl has really overwhelmed the drug supply. I will say that in places where we see heroin or heroin and with fentanyl, that we see a lot less xylazine in the drug supply. But as fentanyl, as you know, the synthesis process for fentanyl is varied with 7+ different synthesis pathways articulated by DEA labs and counting. The kind of fentanyl that we get in the purity is not as high as it has been in the past. So less pure fentanyl may require more of a boost, if you will, an active cut addition. So we've seen tramadol added, we've seen tapentadol added, we've seen other kinds of opioid setting medications that are more available added to boost fentanyl that is poorly synthesized. That xylazine may just be another version of that, more cheaper and accessible one. And so these different approaches for thinking about how and why xylazine is here, the bottom line is it is, and we need to adapt to its presence. So why do we have to adapt? Well, that is because xylazine has a number of important related effects. While we're not talking about, so it sounds like, summing it up, we're not talking about heavy xylazine death. We're not hearing about xylazine only as a drug that is involved in use. We don't see xylazine only in the supply. It's almost always with another opioid. And we're seeing the kinds of overdoses that may be happening very sedated. So what other effects are we talking about? Well, as I alluded to, the use experience and utility is one to consider. But the other components to really think about as health policy and leaders in your community is really thinking about how this is complicating the overdose management, the infectious aspect and other things that xylazine really are worrying. And I guess this is an appropriate time to just acknowledge that there are some, I have at least one image that is visually might be upsetting. So please sort of a warning on that level. But the atypical skin lesions, especially the ulcers and infection that are related to xylazine are of concern for the health and the health of the community and our health systems, but also oversedation effects. People who may be sedated for 5 or 6 hours, for instance, and not moving, have other health-related concerns that are both maybe related to the elements and being outside, especially for our unhoused individuals who may be at risk for assault and other things. So, and I'll touch upon each of these. So first, I guess, on our use experiences, from our ethnographic work, we hear that the experience of xylazine is that it's strong. So it is for some that is a good experience, and for some that is a negative experience. They don't like being out for a long period of time. They don't like having the experiences of not knowing where their time has gone. But for others, helpful sleep aid and having to use less and still get some degree of what they're calling high. Some people say this isn't getting high at all. It's being sedated, heavily sedated isn't high. But indeed, a number of people do articulate that not feeling sick from opioid withdrawal for a long period of time is a positive. So it's something to consider, because there may be other ways we could address withdrawal rather than through xylazine contaminated drug. And then an emerging challenge that we've been tracking in Philadelphia and trying to understand in other places where xylazine presence is increasing and the proportion of xylazine is increasing is those repeated use of xylazine at higher doses will cause dependence. And what Philadelphia is seeing and other places are profound withdrawal symptoms. So while we see hypotension and sedation as an initial experience, the effect of the withdrawal symptoms is hypertension and anxiety and panic attacks and dysphoria, which are problematic when people are looking for treatment and care. So this is something to consider, that both its purpose and how people are experiencing it and its role, but also the considerations of how people are experiencing repeated use. The complicating overdose management is because that prolonged sedation may be even when provided naloxone. So if an individual has taken fentanyl with it or heroin that has xylazine in it and may be experiencing respiratory depression associated with the fentanyl, the naloxone will reverse the overdose component that is related to the respiratory depression of the opioid. But the experience of the sedation, so they're breathing may be restored or low or slow, but they are not experiencing an opioid overdose, but the xylazine is very much in effect. So some have called this, or have thought worrying that what the person is experiencing is an naloxone resistant overdose. It is not that they're naloxone resistant. The naloxone worked as it was supposed to, but it's less effective in a xylazine involved experience. So managing the airway and making sure that there's no aspiration, really making sure that people don't administer too much naloxone in that instance, because when the xylazine does wear off, they will be in extraordinary withdrawal from the loading of naloxone. And that's a concern whether you're talking about high dose naloxone or repeated doses of naloxone. The same thing will happen. The precipitated withdrawal is absolutely something that would require medical attention. So administering naloxone to an effect where breathing is restored and then observing that individual. This has meant for many places that they want to observe and have a safe place to observe people, and being able to monitor their vitals. There are reversal agents in the works and being discussed, but there isn't the same, there is no equivalent of naloxone for xylazine. So this is a challenge for our medical environment right now. The atypical skin lesions and ulcers that may have develop a secondary infection is absolutely a critical component for our healthcare system. Xylazine is associated with and is known to cause ulcers, both at the site of injection, but also outside of that area, and then where people may be using by other routes of administration. They may also suffer ulcers at different parts of their body. They become ulcerative. There are risks of the systemic infections. They can be more complex. They need regular care by a medical professional. That can be a nurse, a street nurse, it can be peers trained with wound care, but the importance of debridement and potential antibiotics and wrapping. It is a slower healing wound, but they absolutely do heal. And there are many messages of hope, many images of hope. While this one is upsetting, individuals do heal, and the unhelpful pathway of amputations is an unfortunate necessary pathway to keep people safe. But the idea of coming into wound care through other pathways, whether it be a hospital or an ED, a clinic, a mobile clinic, or a syringe service program, or any low barrier treatment approach, that wound care is something that we need more support on. And that stigma of wound experiences is absolutely driving people away from our healthcare system. So we may not see an ICD-10 code in our system. In fact, what we see may be a very big underestimate of the true presence of xylazine-related wounds in the community. Thinking about oversedation, those long downtimes with no movement have been articulated as causing circulation effects. Muscle breakdown and kidney injury can happen, compartment syndrome, and then weather-related exposures and concerns. If you're in a place, as we go into the summer, we worry about sun exposures, and in the wintertime we worry about hypothermia. So when we sleep, we still are moving around. You are definitely moving a lot less than during your day, but as it's supposed to, a veterinary sedative is not meant to move that animal or that body. And so the oversedation effects of xylazine means that the individual exposed to xylazine at those doses is not moving. So not moving does open the human to these health problems, as well as the victimization. The last kind of thing to be thinking about is treatment. And I mentioned the withdrawal treatment management is really complicated, and there are data emerging. I encourage you to look at the case study down at the bottom of buprenorphine in combination with gabapentin and clonidine. There are other alpha-2 agonists that might be potentially helpful here, but xylazine dependence is something that we need to learn a lot more about, and to be prepared that induction onto medications for opioid use disorder may be undermined by xylazine. And there's no reason why having a wound or an ulcer of some form would make it impossible for someone to start on medications for opioid use disorder. Quite the opposite, that this would be an opportunity to really treat the whole person. So other health complications and social impacts to think about: physical and sexual violence and harm, as I alluded to, but also the fact that, sedation cannot be controlled. And once folks are out, they're out. And as people talk of what they are losing losing childcare and employment and job opportunities, different things that are time dependent appointments, and their personal care and environmental well-being. So these are Xylazine has a social impact as well. And I think I have two quotes in here from my colleague in Philadelphia's wonderful exploration of early efforts with Xylazine and early exposure, something that more emerging markets like in New England were experiencing. So this individual, a male Latino from Philly, shared, I don't like feeling asleep and waking up and having no idea how I ended up on the floor, or why my arm is sore from, being in an awkward position, or why I have cuts and bruises, and I don't know how I got them. Another gentleman from Black male from Philadelphia shared, and they hate when they get it by accident, because a lot of time bad things will happen to them. They'll pass out somewhere, get robbed, won't remember what happened, all kind of crazy stuff, because there's a lot of people out there that love trank. I don't know why, because it literally puts you out, and then that's when people rob your stuff. So there definitely is a rift of individuals who may be looking and seeking that experience, as I sort of shared a little bit earlier, but there also is a challenge with negative effects, especially for folks who may not be experiencing and expecting the effect of Xylazine. But I think as many of you may be hailing from more rural areas or thinking about rural health, there are absolutely rural health considerations. That isolation that often we talk about in terms of engaging folks in healthcare really has an important role here, because people may have less regular interaction with healthcare providers. Things like noticing a wound or checking in with a healthcare provider may be less frequent. So they may be less likely to also seek medical care because of transportation or a smaller town and stigma. The distances may be great, and our downtime is definitely impacted. So as people may be sedated for a long time, how long they may be also until they are found is something that we need to start to think about, those consequences. And then different resources for healthcare and such are thinking about how to operationalize and support rural areas that may be experiencing heavy Xylazine impacts. So our key challenges are many. Commercially available assay strips, like we have for fentanyl and benzodiazepine, are not fully available. We have limited scientific and real world testing data to support broad use as a strategy in the way that we have for fentanyl test strips. We don't have an antidote like naloxone. And right now, pretty much everything we've put into opioid overdose with respect to this work. And rightfully so, based on the numbers and way too many premature deaths. But what can we make of our current responses to leverage those and think about what else we need to do for Xylazine? Well, one thing maybe not consider immediately, because it won't affect most of these things we're talking about, is scheduling. Several states are looking to schedule Xylazine 5, 3, 4, you pick the number. But we have seen time and time again that scheduling alone and a supply focused alone in a vacuum without thinking about all these other potential health problems, we see a shift to the next thing. And based on our drug checking data and the prominence of synthetic and designer benzodiazepines in this country and in our region, there's a grand risk of losing Xylazine and moving to the next thing that is the sedating next thing that's available. As we've seen in Canada, they have not had trank dope, they've had benzo dope, and benzo dope loads on overdose deaths in ways that are really problematic. So we have to be really thoughtful and strategic in thinking about what we can do and what would make the most public health impact. And in that case, we have responses on treatment and care and in harm reduction in particular that are coming through. And I'll just sort of run through these quickly, but This is the don't throw the baby out with the bathwater part, where naloxone first, knowing that xylazine is present in opioids, that administering naloxone first and foremost, and not losing that piece, though it won't directly affect xylazine, it will absolutely affect the other things that we know are lethal and potentially may be life-threatening. So naloxone, in this case, we have a chance to focus on other aspects of supportive overdose response, like rescue breathing. And back in the day, we would train exclusively on providing rescue breathing and naloxone. I think with more accessible naloxone, we have seen a hyper focus on medication administration. I'm not saying that that's been a bad thing, but it does mean we can't forget the rescue breathing part. And so an emphasis on and making sure people have knowledge of how to provide rescue breathing, both for first responders, our late family members, friends, and otherwise, and staff members who may be coming into contact with and finding individuals who may be overly sedated, and being able to detect for breathing. But rescue breathing is really, really important at that community level. Similarly, recovery positions, so having to leave anyone, making sure that their airway is clear. These are kind of the two components of overdose prevention and response. The overdose response of naloxone, rescue breathing, and recovery position, and certainly calling 911. But many places have been using pulse oximeters. So perhaps during COVID, we had a number of these for symptom tracking available, and they generally measure oxygen levels through a small device that's placed on the finger. They are an inexpensive intervention. There are a lot left over from the COVID era, so there's multiple uses. There are some important data to think about for people with dark skin, nail polish, among other things, in terms of accuracy, but they may be, if available, one thing to add into our local responses for people who are on the ground doing the great work of supporting people with sedation issues. But really a focus on wound care kits distribution and making prevention and early intervention of wounds a real strategy. So that can be through harm reduction providers, community health centers, opioid treatment programs, and other trusted service providers in your communities that can distribute wound care kits and be articulate in preventative and responsive approaches. Communicating and raising awareness about what a xylazine wound looks like. And there's some really great hour-long or longer, if you'd like, for healthcare providers and first responders on what that wound, the beginning of the wound looks like, more progressive wounds, and how to support and communicate awareness about xylazine wounds, and encourage people to come in and get things checked and cared for. And then making care accessible and available. So medical providers can do that on site by providing wound care in the community, not just in institutions. But also we have seen that the need for hospitals and institutions of care to be readied and prepared and thoughtful about the people who may be coming in with abscesses and other xylazine related effects. And that may be things like changing our spaces and changing our processes and procedures. Some places have developed what they call SPOT, or a safe place for observation and treatment, a community response space. Other places have called them sobering centers, in different places that may be working with people involved with stimulants. They may have a safe place for people who might be having a stimulant toxicity. These are spaces that are monitored, usually by a nurse or a trained peer, to allow for people to be observed, and especially if they're going to be experiencing that sedation, so that they can be in a space that's warm and not and free of other outside forces. That preparation for hospitals, as I alluded to, allowing for stigma reduction and trauma-informed care and harm reduction trainings to be in our institutions, so that the care is completed. Leaving AMA is, and without having finished a course of antibiotics, and being able to prepare patients appropriately, prepare the environment for patients who with extreme needs. By the time that people come to the needing a hospitalization, obviously they're going to be in a pretty severe and scared space. So this is a really important opportunity to prepare healthcare providers with trauma-informed care. From our harm reduction partners and other community spaces, that injection hygiene and safety, our own advisory board really strongly suggested thinking about having, though we still see xylazine may be may cause some health effects if it is being smoked, that exacerbation of the ulcer can happen if people are injecting. They may be feeling a lot of pain and then injecting into the wound, and which may make healing more difficult. So even for a short period of time, shifting people to other ways of using if they aren't unable to stop, that safer smoking and other routes of administration can allow for healing of the wounds that people are experiencing. But injection hygiene, like cleaning the site, rotating in the injection site, providing sterile supplies, and reducing the viscosity of the injection with saline and lower gauge syringes are all ways that from the community were suggested ways to help support people who might be exposed to xylazine and experiencing some of these health effects, and can be affected as a policy level. And the last couple thoughts around withdrawal, because xylazine withdrawal is extensive and it's something to think about, but so too is opioid withdrawal. So to the extent that xylazine use is being driven by insufficient opioid withdrawal and supports, we may think about more progressive and expansive ways to provide access to treatment. Lower barrier access, like treating withdrawal, as well as making induction very streamlined, are a couple ways. So in the case of, and I know you're going to be hearing from some folks around pharmacy buprenorphine access. In Rhode Island, we also, in addition to induction, we also expanded withdrawal support. So a single dose of buprenorphine that a pharmacist would assess the individual's withdrawal, levels of withdrawal, and provide per protocol a single dose of buprenorphine to treat withdrawal of opioid from opioid use disorder. This way still can happen in an emergency department. It can happen in a treatment program, of course, but the idea of expanding access to withdrawal supports is potentially another strategy that some communities are working on. And then I think I've spoken a little bit more or a little earlier about the expansion of community drug checking, which is absolutely a mechanism to both see the effect of some of these interventions and track and better target efforts in the communities. And that can allow for things like xylazine awareness, even the simple reflection of what is going on in a community to first responders, to the community, and to community providers, rather health providers and otherwise, and then the public in as many languages as is appropriate for your community. In Massachusetts, it was the 7 that are there on the screen. The messaging that we provided to first responders, both police and EMS, around xylazine are just exemplified here. And they're also up at streetcheck.org, but you can see that they emphasize slightly different things, but in particular, thinking about first responders really needing to reinforce the use of naloxone and to encourage people to seek medical attention when a wound or is either discovered or in the course of the interaction with the community member. And those things being consistent in a community can go a long way. In my own shop and otherwise, we're working on, and community partners at Grayken and UPitt are doing amazing xylazine trainings for health and medical professionals. We have 3 projects that are working on xylazine. One is to validate the xylazine test strip in community drug checking programs using samples that are collected in the community. Another is looking to emphasize how public safety responses to xylazine can be optimized for law enforcement and first responders. And then on the community side, how might people who use drugs and other harm reduction organization staff benefit, and what kinds of prevention and interventions are working for them. So those are a couple places where some research is currently underway. So, and I'll close for some questions and exchanges and all, but just some take home. Really, the drug supply is in a grand state of flux, as it has been for a long time. But xylazine is really part of that change. So we need to adapt to xylazine, and adapting to its presence is important because it has been in the drug supply for some time, and whether that's 90% in Philly or 30 or 40% in New England, this is something we need to quickly adapt to. There are absolutely things that we can do to help our community stay safe. and ways we can respond to help make the harmful effects responded to sooner. So, but of course, lots have changed, lots of research in this area. So maybe we'll be back with some updates on this front, but I look forward to any questions that you may have.
Okay, so we did have a couple of questions. And if you have questions, you can type it in the chat box or the Q&A box. So one question was, I'm curious why Philadelphia appears to be the epicenter for xylazine. Baltimore was also high. This is similar to outbreaks in the past. Is it due to increased surveillance in these areas or something else?
I think there are probably a couple different things. There's some wonderful ethnography kind of looking into this, and in the Philly area in particular, some of the theories have been around because as a known medication that's been misused and used in Puerto Rico, that many of from the Puerto Rican community in response to fentanyl changes during COVID and before restrictions, that xylazine was being added to and experimented with, and it kind of took. And in a community that is closed, especially closed because we were closed ourselves during the pandemic, it spread as an innovation, if you will. It's a maybe iatrogenic innovation, but it is an innovation nonetheless. And so that is one sort of theory that people have talked about, but also these areas, especially in Philly and New England and in Baltimore, the systems of looking and detecting have definitely been invested in very early on. So I think that some of this is being concerned and wanting to mount a response as quickly as possible. So that might be the case too.
Okay, another question is, has there been any research for, oh God, nalmefene?
Nalmefene.
Being used more successfully in fentanyl overdoses when xylazine has been present?
Not that I'm aware of, but it will be on the lookout. Nalmefene was recently approved as a medication for reversal of opioid overdoses, and I think this is like a grand quickly evolving area. So I suspect that we'll hear a lot more about it. It has to, of course, be used, and nalmefene has not been the first line treatment and naloxone has been. So that definitely is an area of new change. I expect to see more data in the year or so. Yeah.
Okay. Several shout outs for your presentation. Another question is, recently in the western area of North Carolina, it has been discovered that the substance is being mixed in cannabis. Does this cause a substance to remain in the system longer?
Cannabis to be smoked. I don't know. I will definitely take that back to my analytic chemist and on my advisory board and put that to her. We explored the addition of fentanyl to crack, to marijuana, and to methamphetamine to determine if burning points, as would typically be had in a crack stem or rolled in different mechanisms for taking in each of those substances, what would happen to fentanyl in those. And then she simulated some in her lab because she could do that. And then we informed a recent safer smoking bulletin, which I'm happy to share with you all. It's being translated now to those seven languages, but the English version is ready. And in that case, we determined that fentanyl cannot be rocked or re-rocked. If you're familiar with how crack is made, or crack can be re-rocked, that fentanyl, and we looked at levamisole, fentanyl, and xylazine, but we didn't incorporate marijuana or cannabis in this case. So the focus was more on safer smoking that we typically see. But I would be glad to look into it and see what I learned from our conversations and exploration.
Okay, and then one other question, and I think so, I don't know. What effects would a law enforcement officer experience if there was an accidental inhalation incident on the road? Would it be similar to fentanyl exposure?
I think that because of the presence of Xylazine's presence is typically found in fentanyl, that it would be in that environment that the exposure would be more likely to occur. And in this case, the more likely are concerns of fentanyl exposure doesn't happen typically through inhalation. You have to really work hard to get fentanyl into the body to get an effect. So in this case, simple hand washing and PPE and universal precautions would be an expected response, but the overdose would not be likely from that kind of exposure.
Okay. And one of the other, I just wanted to remind people that we'll be sending out the presentation audio or the webinar, which includes the slides. If somebody has a burning desire for the actual slide deck themselves, if you would just email me and I can share that. It's a pretty big file. And just 2 more questions, Carrie, and then we can wrap it up. We have great questions. This one might be a little bit longer than the others. So hopefully you can you expand on the buprenorphine without prescription program in Rhode Island in 2 minutes or less?
I would be happy to, and I'd probably also, I can send around to you. We had a New England Journal piece, just a short letter, so it's really easy to read, on induction of patients. We had 100 patients that we were able to, because of the challenge, the expansion of permissions for similar to telehealth with DA and NASCSA, we expanded an existing NIDA-funded study looking at pharmacy-based care for maintenance therapy for buprenorphine that compared to usual care. During COVID, we were able to expand the pharmacists and train them to also do induction. So in that case, they were trained to provide unobserved induction doses and to verify appropriateness for opioid use disorder treatment. And so we inducted 100 patients and had really great findings in that regard. And based on that, they were both had higher rates of returning for retention for a month and not yet out for peer review, but at 3 months as well. So this was really helpful, I think, as thinking about another pathway for treating opioid use disorder. Before we had induction, we thought we've got so much challenge with withdrawal, maybe we could come up with a protocol. So we did treat one patient with that came in for, I believe, 14 separate single doses of buprenorphine over a couple weeks period. And they eventually did shift to become inducted on buprenorphine. We hadn't have our protocol approved for being able to do that in the pharmacy. Otherwise, they would have kind of been able to come in for withdrawal supports, shift to induction, and then continue as a maintenance patient. I wish we could have been able to do that. But this pathway, I'm hoping I'd be happy to come back or have suggest some other speakers who might be helpful on this. But Nevada just passed legislation to allow pharmacists to do this, and about 10 other states currently have the capacity to allow pharmacists to do induction.
Oh, sorry to cut you off. I will mention that actually this topic is one of the topics at the conference. We do have a speaker that's going to be presenting on this, and hopefully have APHA join us as well to sort of do a lay of the land nationally. So Carrie, I think we need to probably try to be mindful of everybody's time. So maybe you can bring it home.
Yep, absolutely. Thank you, Dr. Green. This has been fantastic. I should have put my questions in the chat because I had several. So I may have Kathy send some of those to you because there are questions people have asked me. So once again, thank you, Dr. Green. Thank you, Kathy. This has been an excellent education for NASCSA membership. On behalf of the National Association of State-Controlled Substance Authorities, I'd like to thank everyone who joined us for today's webinar. And again, thank you to our sponsors. We wish you a wonderful rest of your week and a great rest of your day. Thank you.
Thank you.
Thanks, everyone.